So I always knew from the beginning of my career, from my own experience, that you had 2 bites. Every patient has 2 bites, okay? So then the question becomes later on, which bite do I want to treat to? So back in the day, the dentist would blame the lab. Okay, the lab left it high. This can't be my fault, okay? But the second molar is the best example of the 2 bites. So the condyle had changed position a little bit, then you closed down. In dentistry, it was always thought if you squeeze your teeth, well, that's your stress and it's your fault. And so that became the norm. That was the norm for decades. You squeeze your teeth, you're clenching, you're too stressed, it's a stress disorder, so we might have to medicate you. Early on, my TM patients, sometimes they would call and they would go, hey, doc, I have a TM problem. I need Valium. Can you just write me a script for Valium? And then I'll come in next week and you can check. And so back in the day, you go, no, that's not gonna happen. The whole concept that stress is the problem, now I get it, stress gets into the system, okay? But now today, we call that sleep disorder breathing.
In September, I went to New Mexico, Albuquerque to spend time with Dr. Bobby Supple. Now, some of you on the app already saw the wonderful 1-hour presentation that he did for us. I was basically there holding my gimbal, holding my camera, he had the mic on, and he went so deep into abfractions, and it's just the most wholesome piece of content you will ever see on the topic of abfractions. It is comprehensive on the etiology of abfractions and the management of it. So if you haven't already seen that, it's freely available on the app. The funny thing is, this podcast episode was supposed to be about abfractions. We got so sidetracked by the joints and tooth positions that we thought that doing abfractions as a podcast, because what he had was so visual. He had so many great images that he went over. So we decided actually that's better suited on the app as a video. That is not on YouTube. That video on abfraction is golden. It's not on YouTube. It's just on the app, but it's freely available. For those who want, they can get CE as well. But this episode is all about we all have 2 bites. And I saw Bobby speak to his patients and explain this so elegantly to his patients. Like we all struggle in explaining centric relation contact point, and all these occlusal aspects to our patients. It's actually difficult for them to understand these super complex topics that took us years to understand, right? But essentially, he elegantly says that we have 2 bites. We have a daytime chewing, eating teeth bite. And this is like the bite that we have when we're standing up or in a vertical position. And you can call this your maximum intercuspal position. Bite together and all your teeth hit. But we all know that we have a second bite. This is why textbooks exist in occlusion. This is why deprogramming exists. This is why leaf gauges exist. And this second bite Bobby calls your nighttime posture, breathing, swallowing, and sleeping bite, or your airway bite. And that's when we're laying down and the mandible is in a neutral position. This is when the condyles are home and they're seated and they're snug. And to cut a long story short, his aim as a restorative practitioner is to slowly help patients to try to reduce the discrepancy between bite 1 and bite 2 and align them as closely as possible over time. Look, Bobby, if you're listening to this, it was so amazing to spend those days with you in the clinic. Thank you for taking me under your wing and your mentorship and guidance. I went away really inspired, and I'm so happy to share this podcast with everyone today. Hello, Protrusive, I'm Jaz AI, and welcome back to your favorite dental podcast. On this podcast today, we look at centric relation in a different way. It's presented in a different way, and we need that in dentistry and occlusion. Sometimes something doesn't make sense until you hear it in a different way. So I do hope you enjoy the chat with Bobby today. Now, every PDP episode, I give you a protrusive dental pearl. Hey guys, the protrusive dental pearl today is very different, right? I have on the phone with me, Jaz Gulati. I've got AI Jaz on the phone with me right now. This is the new feature coming on the app. It is literally a clone of my mind. Every single course I've ever been on, every single course I've ever delivered, every single podcast episode with a guest, and all that knowledge is squeezed into this. Hello, Protrusive. It's Jaz here, ready to chop some onions with me. Whether you're battling a tricky case, losing sleep over occlusion, or figuring out the next step in your career, I'm here to help. Tell me what you're wrestling with today and give me a bit of context. We'll slice it into clear, doable steps together. All right, Jaz, give me a protrusive dental pearl that I can share for this episode I did with Bobby Supple, maybe related to abfractions, because that's a recent episode that we did together on the app. Maybe a top tip we can give about abfractions. Here's the vibe for a top tip on ab fractures from that episode with Bobby Supple. Always check the patient's bite with them seated and then lying down. because posture literally shifts the condylar position and how those fractures might load or hurt. That simple check can clue you into hidden stresses causing the crack to worsen before you even lift a hand. It's like getting 2 bites for the price of 1, revealing what's really happening beneath the surface. So what you're saying is when you're investigating the etiology of abfraction, you need to see if that tooth in question is under excessive load. But if you just do this in one postural position, it's not going to be enough. You need to do it on your check the bite when they're laying down and when they're sat up. Is this for like diagnosing abfraction, or is this once you've restored the abfraction?
You nailed it. This double posture bite check is about uncovering excessive load on that tooth that might not show up if you only check them sitting upright. It's mostly a diagnostic move before you restore, to catch those hidden force patterns that can worsen abfractions later. After restoration, it's still useful, but more about confirming your work isn't creating new stress.
Well, there we have it, guys. Thank you, Jaz. AI Jaz has just told us to check the patient's bite, especially in those abfraction cases. If you're restoring abfraction, check their bite when they're laying down and check their bite when they're sat up, just to make sure that the tooth is not overloaded in both those scenarios. And that in turn will help your restorations not have the same fate that the tooth did, i.e. the abfraction happened as an overload, as a flex. And again, in the video on protrusive guidance, we went deep into it because it's not just occlusion, it's not just overload. There's more to it than that. So you have to check out the app for that. Anyway, I hope you found that pretty cool. Now let's now check out the main episode and I'll catch you in the outro.
Hello, Protrusive, I'm Jaz Galati, and I'm in Albuquerque, New Mexico. Can you pinch me, please? Can you just pinch me? Okay, I am with Dr. Bobby Supple. I cannot believe it. I've had the most wonderful last few days with him, and I kind of twisted an arm and said, please, let's do a podcast episode. Now, this gentleman here with me right now, so knowledgeable, right? We can literally fill up podcasts about communication, the way I saw that he communicated with his patients. Leadership, okay, what an amazing leader. We already did a history of occlusion. We did Occlusion Wars Part 1 and Part 2, so please do check that one out. But one thing I thought that would be really good to discuss, because it was like a little project of yours in the past, was abfraction, and something that dentists like Adi is on our community, and she actually said, look, she'd actually like to learn. She saw your work and said, can we discuss about abfraction? And to be honest with you, I am agnostic about abfraction. I hear so many different viewpoints that I would love to know from all the reading, the research. And what I love about Bobby is that he's got like T-scan data that marries up, so he can tell us, is occlusion relevant or not? So there's so much I want to pick up. But Bobby, just in case there's someone out there who doesn't know about you and your philosophy and your role within AES and all these wonderful things that you do, can you please reintroduce yourself to the Protrusive worldwide and tell us what you stand for?
Yeah, my pleasure. And I thank you for coming. Yeah, it's been absolutely a killer couple of days. We've had a lot of fun together. And so what happened with me, I'm 15 years old. I'm a swimmer. And before water polo practice one day, we're goofing around on a diving board. And I came down and my friend was double bouncing me. I missed the board with my feet. The diving board hit me here. I broke my mandible. I cracked it here.
Just as Bobby said that his jaw broke, the whole camera setup broke. But anyway, so you're 15.
Perfect. So 15 years old. And pass out. I'm in the swimming pool. They pull me out. And then I wake up kind of basically in the hospital. And so I had to have my jaw wired shut and that sort of thing. I had no intention of being a dentist. Dentistry never even occurred to me until that. The concept of, oh, I think I could be a dentist. I think I could do this. I think I could put people's jaw back together, because I was kind of fascinated by it. But the docs who put me back together, they actually turned out to be mentors in my life after I graduated from dental school. So that was an interesting pearl. But I'm a swimmer, so I go to University of Houston. I swim at Houston. Lucky to get into dental school, I go to Tufts. So now I'm at Tufts. And then I didn't learn anything about my jaw in dental school. Zero. We didn't even have radiographs. We didn't even really have a panel back then to look at the joints, image the joints and that sort of thing. But I went all the way through dental school, even though we did learn about occlusion to some degree. I did not learn a single thing about my jaw joints in dental school. So now I have a mission. Now I'm on a mission to sort of figure out about TM joints. Because I had my own personal experience and had just finished orthodontics, and then I had my bicuspids taken out. So the wisdom teeth came in. So I still have my wisdom teeth, but I lost 4 bicuspids. That was previous to my accident. So I knew my bite in dental school wasn't quite right. Didn't know why, pretty much assumed. I didn't really have any pain or any kind of problems with it. I just knew that when I chewed on one side was a little different than when I chewed on the other side. I was young, and so basically it wasn't a problem, and things were adapting, everything was fine. Now, I did have some professors at Tufts, a number of them, but they kind of like educated me a little bit about it, but mostly it was all dental. It's how to mount your models correctly, take a face bow, those sort of things. And then after dental school, came back, practiced for a couple years. First place I went was Pankey Institute. Pankey Institute, I actually did learn a little bit about deprogramming the first time I was at the Pankey Institute. So I tried a little deprogrammer. It was acrylic at the time. You would just roll it up and kind of mold it and put it
Like a
in.
Lucia jig.
It was like a Lucia jig, and it would then it would heat up, and it was in your mouth, and so it's a little bit of a weird experience. But I wore that a little bit, wore it some at nighttime, and knew that I had 2 bites. So from that point on in my career, early on, so this is like 1982, 83, I go, oh, I have 2 bites. I have my teeth bite, but I have a jaw orientation bite, and the 2 are a little bit different. And so when I would take out the little deprogrammer, then it would be a little on one side. And then after I wore the deprogrammer for a little bit, sometimes a couple of nights, and then mark it with articulating paper, and it had changed. So my mandible position was changing a little bit, and it was simply moving to the side that my jaw joint was broken. So I go, perfect. I go, okay, now I could center myself up a little bit better. Again, didn't think too much about it.
Can I just clarify for
Sure.
some of the younger colleagues listening? Is this the same as your MIP being your day bite, your maximum intercostal position, and then what some authorities would call the centric relation position, or the centric relation contact point, or the old term retruded contact position? Would that be a similar way to think about it in terms of what you experience and what you're describing here?
Bingo. That's correct. But the terminology got in the way of the problem. So what happened is we would say words like centric or centric relation or adapted centric posture. It would change. It seemed like it was the new flavor of the decade was, okay, we're changing it. And there were 7 definitions of CR. And Jay Levy said we need an 8th. We need to add the neck, the atlas into it because there's a relationship there. So the point is centric just simply means center.
Okay guys, let's do some interjections. I know you're all going to love these interjections, especially when we have a more confusing topic that would really benefit from just a moment to pause and just clarify a few things. So let's talk about the big one straight away. Centric relation versus MIP versus something called ACP, which is adapted centric posture. Let's start with the easy one first. Let's start with MIP, maximum intercostal position. It's how, when I tell you to bite down hard, your teeth just fit together. It's the bite of best fit. It's the tap, tap, tap for when you're doing like a single tooth restoration to make sure everything is happy and balanced in that one bite. And the clue is in the name, right? Maximum intercuspal. In which position do the cusps maximally meet the most and the best? And this is totally a tooth determined position. It doesn't tell you anything about the condyles. It just tells you that this is how this patient's teeth come together. And in most patients where you have plenty of teeth and good enough anatomy, they bite in one place every time. It's also called the habitual occlusion. So that's the easy one. That's the one that 99% of dentists work in, day out. And the next one to tackle is centric relation. Now, whereas MIP was something to do with the teeth, centric relation isn't quite to do with the teeth. It's actually to do with the jaw joint. It's to do with the condyles and the glenoid fossa. And something that we describe in our OBAB visual glossary, our online course, we talk about our visual glossary. Now you can imagine Goldilocks might say, you know what, this condyle is too far posterior. Or this condyle is too far inferior, or this condyle doesn't really have a disc between it, and therefore this is not centric relation. And then you find the one that's just right. And in this just right position, bear in mind that the definition of centric relation has changed over the years and over the decades, but what we accept it as now, and it's also known as stable condylar position, which actually helps, I think. It's supposed to be superior. So if you imagine the shape of the articular eminence, it's like an upside down U, and therefore the condyle is going to be at the highest point. It's also going to be at the most anterior point, so it's braced against bone, and ideally it's going to have a disc there. Even though the GPT-9 definition forgot about this poor, unappreciated disc, in an ideal world, centric relation is something you find on healthy joints, and it's a stable, snug, repeatable position. Me and Mahmood joke in our courses that the ball is in the cup. When you drop a bouncy ball into a cup, it's only going to go one place, right? It's going to go right to the bottom, and it's going to equalize itself in the middle somewhere. In the same way, if you were to push on a condyle, it will find itself into the shape of the glenoid fossa. It will find itself home into centric relation. Now, at this point, the teeth could be doing anything. And more often than not, they might be just hitting, one point on the second molar. That's centric relation contact point. That's not really centric relation. Centric relation, all it is, guys, is a good reference position. And the way I've described it is an anatomical position. And we're going to be talking a lot about it in this episode. So we refer to this as bite 2. And so lastly, ACP, adapted centric posture. Now, let's imagine a scenario whereby the disc is not in position or the shape of the condyle is now structurally damaged. Does this mean that there's no hope of doing any reorganized dentistry on this patient, and this patient can never have full mouth implants or never have complete dentures or never do anything in a reorganized approach? Well, of course they can, right? Because whilst there is some damage structurally, the condylar anatomy undergoes adaptation. Remember, the TMJ is the miracle joint. Therefore, ACP is this kind of scenario where, the disc is not in a great position, or structurally the shape of the condyle doesn't look like a potato anymore. However, it is still in a repeatable place. The patient's asymptomatic, not really getting any symptoms or locking. And you can even put some load in the condyle and the patient does not respond in pain. And once again, repeatability, repeatability, repeatability. And so we call that an adapted joint, or an ACP, adapted centric posture. Now, I also asked our shiny new AI platform that will live on the app. It's something I've literally just announced, obviously. And if you ask it, it actually gives you some great references, and it describes here. It's called AskJaz, by the way. And AskJaz says it's coined by Peter Dawson. And it's basically the joint saying, I'm adapted to function here without drama. Do you love these jazzisms? Like, I've literally made AskJaz to sound and speak just like me. I'm just excited to talk about it. I just want to just let you know that any such niggles and questions, you can pick up the phone and call Jaz. You can call me anytime now. You can call me in Italian. You can call me in Chinese. You can call me in several other languages. Call me in Hindi. I showed my parents AskJaz Hindi last night and they were blown away. So I hope that clarifies centric relation, MIP, and ACP. But remember, this is just a journey. If you're inspired to learn more, instead of going on Google or ChatGPT, I would ask Jaz, my digital mind, and you could check that out on Protrusive Guidance.
So then when I got introduced to Dr. Dawson and went to some of his courses, then I learned to manipulate and learned to put the condyle, say, back into the socket. Now, to answer your question, it was, okay, today I tell my patients this all the time because it helps it when I want them to wear an orthotic to sleep at nighttime. So, or sell them a splint, so to speak, but I don't usually use the word splint. I use the words orthotics because we're going to put the condyles back home, okay? So I tell my patients, okay, everybody has 2 bites. You have your daytime eating, chewing, teeth bite that you are in a vertical position. And then you have a nighttime bite where you're in a horizontal position. And that is where your mandible is in a neutral posture. And that is your breathing, swallowing, sleeping posture, airway bite. So I break them up like that. So one is vertical, one's horizontal, one is teeth, which now we just go, okay, well, that's MIP, okay. And then when I lay the patient down in the chair and manipulate them and close them down, and I used to go, this is your first point of contact, hit, squeeze, slide. So we went through that process for years and years because I wanted the patient to feel that.
Okay, quick one, guys. Interjection number 2. Let's just clarify. Bite 1 versus bite 2. Bite 1, he calls it the vertical bite. Like you're standing up. You're standing up. And obviously we're not laying down when we're chewing. We're sitting up. We're sitting up. We're standing up. And so this is like you're chewing daytime MIP bite. When you stood up, tap, 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 you bite together, you swallow, you go into your MIP. Remember, we talk about MIP. So there's a way that our jaw functions in this upright position during the day. Let's call this bite 1. And then bite 2 is our horizontal bite, i.e. you are laying down. You're laying down your back, for example, and so you're supine, kind of like our patients in the dental chair. And this is our breathing, swallowing, sleeping airway bite. So it really emphasizes the impact of posture on the position of the jaw and the way our teeth come together, because our teeth may still come together in MIP, but the way they come together might be different depending on the way your posture is assembled. It might be easier for you, for example, during the day to tap, tap, tap and bring your teeth together in one position every time. When you're laying back, and you're trying to lay back, or rather do this, extend your chin all the way up, okay? And now slowly start biting together. You see? Many of you may have felt that the back teeth hit first and then it slid forward into your MIP. So eventually it maybe got to MIP, but the path was a bit different. So bite 1 during the day, bite 2 in our sleep is the simple clarification.
Now, later on, when I got into T-scan, so it was 1987 when T-scan was first invented, but it was invented at Tufts with my professors that I had gone to school with. So
Just describe what T-scan is.
all right, so T-scan is a sensor. So instead of bite paper, then you just simply put a sensor in the mouth, close, swallow, squeeze. You can tap. You could actually chew in it, but it tears up the sensor a little bit. But mostly it's close, swallow, squeeze, tap, and tap. We add a squeeze, tap, 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 and then squeeze in our diagnostic protocol. So if I take a T-scan sensor and I have the patient sitting up, it will give me one bite pattern. If I take the patient and I lay them down horizontal in the chair and I stretch them out, or maybe I just massage the muscles just a little bit and then have them close down on the sensor in this position, it gives me a different pattern. So I can measure the difference of the two bites relatively
Kind of like
quickly.
saying what kind of slide are we up against here?
Yeah, so what mostly I'm looking for is first point of contact. Where is it in the arch? Is it in the very back? Is it in a corner? Is it in the side? Does a bite go this way? Does it hit in the front teeth first and go back? Okay, so there's all kinds of different mandibular positions or mandibular patterns.
You've given me the papers for all this. So what I love about Bobby is that, I mean, it was just so nice. And I've made videos, little snippets, which I'll share on the community. But like how diligently he's got this lovely library, which I'll share videos of. And he made me like this little goodie bag of seminal papers and literature. And so some of those, you said you're happy for me to share them with the community. So I'll make them available to you guys because I think they're just essential reading. It's hand-picked by Dr. Bobby Supple in terms of, okay, this is great to read as really important information for our understanding of occlusion.
Good. Yeah. So T-scan started in the 90s. So I was an early adopter to the T-scan. The first sensors, T-scan 1, 2, 3, was simply you close down and it gave you 5 pressure points. So you would have an arch and kind of simulated where the teeth were going to be. And then you had 5 points. It gave you an X and O in a square, and you could put an X in a square, an X in a circle, but it was like a steak. It gave you light, a medium, rare contact, medium well, and a heavy contact. So you had 5 pressure points. The pressure points showed you, at least in the arch, when they hit, it showed you the location of where those pressure points were. Okay, so what I was looking for in the early days is close down, and I wanted to know my anterior control. Okay, so you have condylar guidance, and then you have anterior guidance. Dentistry thinks as anterior guidance more as canine disclusion. So we think of anterior guidance off from canine to canine. That's not what anterior means to the master teachers.
Hey guys, Jaz again, interjection 3. What is this anterior control? So anterior control, just to really break it down, is basically the first point of contact, like what I usually call centric relation contact point. If it's on a back tooth usually, or sometimes in a premolar, why is it called the anterior control? Well, It's one of those terminology things in occlusion. It's anterior to the condyles. It's anterior to the posterior determinants of occlusion. The condyles and TMJ are the starting point for occlusion. So your anterior control, all it means is that when your condyles are in centric relation, when the jaw then comes together, which is the first area it hits. Specifically, while your condyles are in that snug superior anterior position we spoke about. That's our anterior control. Nothing to do with anterior guidance. Back to the episode.
So the master teachers always said anterior means anterior to the condyles. So if you close down and the first point that touches is, say, tooth 14, distal buccal cusp, okay, then...
So that's upper left 6 for the Brits out there.
My apologies
No,
for...
because it's international audience, it's all good. I just want to say it both ways.
For being a Yank, but that's
Two
how we
things.
do it. So it's upper 6, so distal buccal cusp. Okay, so if that's the first point, now that is now your anterior control.
AKA centric relation contact point, retruded contact position, all these terms. I'm just the reason I'm throwing these out there is I'm trying to get rid of these or just throw some synonyms out there so people say, oh, okay, if I don't know it like this, it might be the first time someone's heard anterior control, but then they'll relate to retruded contact position or they'll relate to centric relation contact position. So we're talking about the same thing here.
Exactly. Remember, flavor of the decade,
Yeah,
okay?
yeah.
Because it all changes as things evolve.
So you're able to report that in the T-scan.
Sometimes we mess it up as time goes on. So I try to dilute it as much as possible. But the first point of contact is, I called it your anterior control. So now that's the first tooth that is controlling the condylar position. And then you would squeeze, and then the mandible would close into MIP. And even when you're laying down, squeeze down, the patient can find MIP. Okay, so now that always set up. So I always knew from the beginning of my career, from my own experience, that you had 2 bites. Every patient has 2 bites. Okay, so then the question becomes later on, which bite do I want to treat to? Okay. Now, eventually, I just said, no, I'm just treating to condylar position first, even though that was off. So early on, we quickly figured out with just some deprogramming splints in the 80s, patients did better. They did a lot better. They would wear it at nighttime. In the beginning, I thought, well, I'm just centering the condyles to get to my dentistry. So my dentistry could be a little bit better. And we had started equilibration at that time, but you were equilibrating the dentition for the purpose of getting your restorative right. So Dr. Dawson, he loved the T-scan. He had the early versions, Gordon Christensen. So some of my mentors go to their office. There's the T-scan in the office. Okay. Now, Dr. Dawson used the T-scan early on, the first to check his models. He wasn't using the sensor. Remember, it was just 5 dots. Okay. So he would have his mounted model, so everything in line up, and then he would close on it, and he knew where the first point of contact was from either records or whatever. And then he always took a CR bite as opposed to an MIP bite, okay? Condyles in, close down, get a bite registration, mount your models in a condylar seated position, okay? So that's how it started. And then he would take the sensor and close on his articulated models to see how well the models were mounted.
As opposed to using articulating paper to check that, he was using the sensor to give him the...
Exactly. And then quickly go to articulating paper, tap, and then go, and that sort of thing. And then that then turned into trial equilibration on the models. Okay, you had it, so you would do a little adjustment. And then that was now you're changing your anterior control from, say, 1 point to 2 or 3 points. And then finally little polishing. And then finally what you were looking at for 4 or 5 points on one side that also were in balance with 4 or 5 on the other side. Not necessarily canine touching position, okay? Just balancing out left and right side. Sometimes it involved the distal of the canine, okay? But mostly that was the early days, okay? So then in 1995, so Windows changed everything. We still, at that time, didn't even have laptops in the operatory. We didn't have computers in the operatory until after Windows 95. Then that literally started to change everything, okay? So when Windows 95 came out, then T-Scan upgraded, and now we went from 5 dots to 50. So there was 50 intensity. I call it 50 shades of gray. So all of a sudden what happened is you had colors, and then you could have the patient tap up and down, and then you could record timing, and you had timing graphs. And basically what happened is we were into the digital age occlusion without even knowing it, which is actually the beginning of AI way back when Windows started, okay? It's kind of, you look back on it now and you can see the evolution of digital occlusion, and then we were just adding other digital metrics as time went on, okay? All right, so now what happened is now you had timing. All right, so in the first phase of T-Scan, just the dots up and down, they were occlusion dots. It was closing dots. That's all you had. But when you put it into a 3D, and then you had what we see now is the the T-Scan that we're used to, colors, you can do it in pixels, and you had timing graphs, then everything changed, but we didn't know early on how to interpret the scans. There was so much information, and instead of just a couple of dots, every 100th of a second, the dots were changing intensity, and so they were like literally going up and down and changing colors, and you're like, oh my gosh, it's like, there's so much information here, your mind couldn't get around it because you were thinking close. You were just literally in that mode. That's the way you close your models, like that, okay? What happened is quickly, mostly Robert Kirstein, he was the one who started to say, wait a second, this timing, you have disclusion. Okay, so disclusion is now the push off. All right, so now that changed everything. It's like, okay, wait a second. Everybody can get into MIP, but then the real problem is, how do you get out of MIP? So that's a twister to the mind that a lot of dentists still have trouble with. So I call it getting into and out of MIP. All right, so now
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on Protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wide wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
The best analogy that you want to think about it is, let's say you had one leg shorter than another, and then you stepped. So you can step just fine. It's the push off where all the torque is. So as you're pushing off, there's a twisting motion into it. And then it was very easy to see in the timing close, squeeze, but you could now see opening because it would measure it in hundredths of a second. So once you were into MIP, then there's a short period of time, fractions of seconds, but you were measuring in hundredths of a second. The newer T-scan version, the hypo could measure it in a thousandths of a second, okay? But that short period of time, you could see which teeth were pushing off. Now, that's disclusion as opposed to occlusion. All right. Now, most of your interferences are easily found in disclusion. So you have protrusive podcasts. Well, maybe we should turn it to protrusive retrusive podcasts with it like that, because dentistry, we mount our models and you close them down. And everything we're doing, let's go forwards and backwards, let's go left and right. But what we don't measure, we don't have the ability, because the condyles are locked, we don't have the ability on an articulator to measure retrusion, okay? So disclusion and retrusion is where the heaviest interferences are found. All right. It takes a while to practice on the computers to see that, because you have to look at the timing graph and you have to stop and freeze the frame and see which tooth is pushing off, okay? So what happened by the time, if you're just sitting up, by the time you close down, you've already gone around the interference. Now you're in MIP. Well, you can do that bite all day. And then, honestly, that's how dentistry is done. Perfect. I have no problem with it. I will say this. One of the reasons why we get away with so much in dentistry is because we do dentistry laying down. So when you're doing a laying down, the mandible seats a little bit. Okay, the neck shuts off because you have your head on a pillow, so the neck will relax a little bit. And then as the patient closes down and we're checking, say, our temporaries, or we're inserting a crown, we're coming in at a steeper angle, so the patient doesn't adapt so much. And then we go to do our little adjustment and the patient sits up, and many times they're fine. But if the patient sits up and says, oh, it's high, every dentist in the world goes, okay, I'm not going to leave it high, okay, because it's a proprioception. So then they'll check it in and go down. So essentially, when we say seat a single crown, a single unit crown, we are always building it lightly out of occlusion. We don't ever leave a restoration high because the patient's perception is it's high when they sit up. Okay. So we may think, okay, they close down, but sometimes the interference is on the opposite side that we're working. We're tapping up or down. The patient sits up. So another tooth is guiding them, and then it feels high to the patient. Okay. But we just quickly adjust and adapt. Now, when you do a second molar crown, every dentist kind of knows this now. Say you prep the second molar, okay, and then you're doing the provisional, and they start tapping on the provisional, and you go, well, that's quite high. Okay, so you kind of adjust it down. And sometimes then you'll look and you'll go, oh, I didn't take enough off. So, oh my gosh, I think that I need a little bit more occlusal clearance. And then you, same thing, provisional, okay. And then you'll build the provisional out of the bite a little bit. Then the condyle will seat up a little bit more. And now you go to insert the crown and it's high. So back in the day, the dentist would blame the lab. Okay, lab left it high. This can't be my fault, okay? But the second molar is the best example of the two bites. So the condyle had changed position a little bit, then you close down.
Hey guys, Jaz again. Introduction number 4. Right, second molars. They are a nuisance, but they're a prime example of the concept of us having two bites, bite 1 and bite 2. And so whilst it would take me a whole hour to do an interjection on second molars and how you can lose a space, like you prep for a crown, you swear you prep for 1.5, 2 millimeters, and the patient close together and woof, all the space is gone. So bite 1, bite 2 is really applicable in those scenarios. So I would suggest that you check out the episode that me and Mahmood did. It was PDP252, I think about 3 years ago. Last tooth in the arch syndrome, second molar conundrum. It's got over 10,000 views just on YouTube alone. And it's also something that we cover in our in-person courses. I remember one delegate messaging us saying, oh my God, I'm so glad I came in your course. It saved my bacon. I was able to have a chat with my patient and predict that their bite was going to change before it changed, and that completely changed how we manage that second molar. So please do check out PDP252, last tooth in the arch syndrome, if you want to go deeper into this, because I think as general dentists, it's going to happen eventually. You do enough second molars, eventually this conundrum happens, so you need to understand it and screen for it, which is something that we go over.
Now with zirconium, now that zirconium is in the mix as opposed to gold that I used for 30 years, okay, then the zirconium is so hard, it's like a non-precious metal crown. And so they're not forgiving at all. So if between your prep and your provisional that the patient's wearing, and then this seating appointment, even myself, even sometimes when I thought I had everything lined up and going, and I look at it and I go to seat it, and then while the patient was in the provisional and they were functioning, sometimes they didn't want to mess with their temporary, so they chewed on the other side. So sometimes there's an adaptive chewing pattern between prep and insertion. Okay, so the muscles are going to change a little bit, but as their patient is doing that, they're scrambling things a little bit, and then they come back in and you insert it and it's high. Many times you do that and you'll get it and I think I got the bite just fine. The patient sits up, that feels fine. And then they come back at another time, sometimes a hygiene visit, maybe months down the road, and they go, Doc, I still think I'm hitting it a little hard. Okay, so what happened? It's just literally the condyles are the one that are changing shape. Okay, so condylar guidance and anterior guidance, they ideally should be independent of each other. If condylar guidance can do its thing and is happy, and you go to eat and chew and the bite is happy, and the two are not interfering with each other, you're fine. But that's rare, okay? Yeah. That's the pure patient, the perfect bite patient. Nobody
Minimal
really
wear,
has a
minimal wear, ages well.
Not class 2 at all. Almost kind of like end-to-end occlusion, not necessarily class 3, but nice tall teeth, not wear facets on the teeth. So there's some of those bites around, okay, but they're rare. That's not the norm. Everybody's got some kind of adaptation. So now we look at airway first. So the side that the nasal airway is generally the least. So if a turbinate bulges out and the maxillary zygoma bone rotates and then the ears aren't quite level, they put on glasses, they go downhill, and the two sockets aren't quite in the level. So you see that on your panels very easy now. Okay, so what happens is most of the asymmetry is in the mid-cranial face. You just draw a line, turbinates, you're going to go right past the cheekbones, right to the TM joints, right through the ear, and now you're going to go back into the mastoid process with it, and then you can feel a little tightness with it. So the way I describe it to the patient is you have a little skeletal asymmetry. They can deal with that. That's fine. Tall, short, left-handed, right-handed, that's how it all grew. Now it's called epigenetics because we have inflammation in the system. That's another podcast. But what simply happens is your maxilla arch, so the palate is 2 bones, okay? The mandible is 1. So your upper arch is a little bit like a V on mostly one side. Sometimes it's bilateral. Okay, and your mandible is like a U, and a U doesn't fit inside of a V, so the patient grows into a pattern. Now, if there's a lot of inflammation with the children growing up, so say one side, they don't breathe through their nose at all, or they have a lot of allergies, postnasal drip. So that child at 6 years old cannot breathe this. Doesn't happen. So they have to tilt their head, and that's how they open up their airway. Some of them suck their thumb. So kids suck their thumb to breathe, not because they don't have a blanket, okay, or it's some kind of stress sort of thing, okay? So in dentistry, it was always thought if you squeeze your teeth, well, that's you're stressed and it's your fault. And so that became the norm. That was the norm for decades. You squeeze your teeth, you're clenching, you're too stressed, it's a stress disorder, so we might have to medicate you. Early on, my TM patients, sometimes they would call and they would go, hey, doc, I have a TM problem. I need Valium. Can you just write me a script for Valium? And then I'll come in next week and you can check. And so back in the day, you go, no, that's not going to happen into it. But it was thought that TMD, then I remember some of my early slides was TMJ in a circle with an X across it is not a Valium deficiency. Okay, so the whole concept that stress is the problem, now I get it, stress gets into the system, okay, but now today we call that sleep disorder breathing. So the reason that patients squeeze their teeth is to breathe. Close, swallow, squeeze, press off. It doesn't mean that they have apnea. It doesn't mean that but they're going to head in that direction. And usually that is an airway issue. But then there's going to be the adaptation, much like one leg shorter than the other. Okay, now patients get that. They understand, oh, I have that. So I say, okay, well, your problem isn't closing down. Your problem is the push off because you have an asymmetry. So patients get that.
I mean, I just want to say I saw this firsthand, right? So I was shadowing, literally like I was your shadow over the last couple of days, and I saw you on your new patient day and on the returning patients. Sometimes you'd be saying this, and patients were like just understanding so well. And then what Bobby does, on an OPG, he can draw the line and show the asymmetry and how one condyle is significantly more seated than the other, and how that links back to the turbinates, the airways. And then the most fascinating thing was that he'd reach out for the neck, and he was able to pinpoint in the trapezius exactly the painful spot every time. It was just amazing how he was able to just look at the history, look at the patient's face, look at the asymmetry, look at the OPG, and just figure it out in just quick time. Obviously that took years and years and years, but what I saw was amazing. But I also saw the other side. I didn't just see you see the new patients and give this explanation. I saw patients that have been with you for 10, 15, 20, 30 years, and they were like so thankful, like, wow, I used to suffer with migraine so much. I used to have this issue, I used to have popping, and I feel I'm in such a good place. And all these patients had well cared for, well looked after orthotics that they would bring, but it all starts with that initial diagnosis and explanation, and you say it in a way that patients just get it. So I was there frantically making notes on how I can explain, use the flat tire analogy as well and everything. So I just loved everything that you said, and it was just communication masterclass.
Okay, yeah, I appreciate that. And that's true, that the verbal skills took years to develop, but we've been in that mode since the turn of the century, actually, okay? But it all goes down to 2 bites. You can have whatever philosophy you want. They all work. They all open the vertical up a little bit. And so it can be neuromuscular, it can be bioaesthetic, it can be like, okay, just CR. It could be MIP. It could be we just work in the adaptive bite, and that's how 90% of dentistry is done, and it works fine. Okay, but basically what you're doing with the teeth bite is you're just building it out of the way. Now you do that enough times with an asymmetry, and then now the restorations are not balanced together. So a lot of times what happens is a patient will come in, if they have at least 3 restorations, like 3 crowns, for example, they might be different materials, different times, made at different dentists
Piecemeal dentistry.
for different reasons, but they don't wear the same, and they were all built to an adaptive bite. So it's
MIP.
MIP. So at some point in time, you have to stop. And I use this analogy with the patients all the time. I said, I want you to think of your crown or a restoration. It can be silver, it can be even composite. All right. Oftentimes it's gold or PVC, or now some kind of a zirconium. Okay. So I want you to think of your crown like a tire. Okay. I go, your existing crowns are well done. What you need is a rear end alignment. And they go, okay. I said, look at this tire. You're wearing it sideways. You're going to wear it bald off the side. And almost, because we have a photographic picture of the tooth, so Jaz saw that. So the first thing I'm going to tell every dentist that starts, whether their first day out of school or been going for a while and they want to learn about occlusion, you get a camera. You start taking photographs, and we photograph the palate and the tongue and all of that sort of thing. So again, we'll do that in another podcast. Okay, what you're looking for when you take the photographs. But I have a photograph, or you can simply, if you want, you can just take your intraoral camera and then take a little click into it. But you will generally have some kind of stress at the CEJ. You're either going to see it in terms of recession, or we're going to talk about abfractions in a moment or so. So you have some kind of chronic stress. I learned very on in my career, every acute problem has a chronic condition behind it. And so it could be as simple as just a little tiny microfracture, but still that microfracture has some kind of chronic adaptation around it. That's why I love the T-scan, because it's easy for me to figure out the 2 bites. So we wrote about it in a book, one of Robert Kirstein's computerized dentistry books. But what I want the audience to know is every patient has 2 bites. The patient understands that. You can understand that. One is a teeth-oriented MIP bite, and the other is a posture, airway, breathing, swallowing, sleeping, horizontal mandible position.
So is the goal always to get them from having 2 bites to the 1 bite?
In my world, yes, they do really well. So TM joints, it used to be, okay, well, it's a stress disorder. There's nothing that you can do about it. But Danya Tamimi, she teaches us, and I've known it for decades. Many of us have always known it. These joints remodel. They have the ability to remodel unlike any other joint in the body because they work by hydraulics. Okay, so then the adaptive sort of pseudo disc is the word that they started to use. Okay. The adaptive pseudo disc, these joints get better. So Danya now calls TMJ the magic joint, the miracle joint. All right. So now you have to go, okay, how do we get the patient into those magical positions? And then how do you stay? So that's what you saw with some of the patients who've been here for a while that came in and they started locked or they started migraine. And now they open and close and left and right. Now they still, almost all of them still wear their orthotic at nighttime. And then they'll come in. So I'll see them at 6 months, year intervals. And there's always some kind of little marking on the orthotic. So sometimes we look at the orthotics and you see the little lines and you see the little squeeze dots into it. And so our immediate assumption is, oh, this is brexing. The patient's brexing their teeth at nighttime. Mostly that's wrong. Some do, okay, but that's pretty rare, okay? Mostly what you do when the orthotics are balanced and the joints are remodeling, so they're changing position a little bit. So it takes time. Patients will come in and their jaw is popping, and I go, we're going to solve that problem. Might take me a while to solve it, but then they'll come in down the road. My jaw doesn't pop anymore, okay? But that's not what's happened. Is it's the human body that's fixed it. I just put them in a position for their immune system to be able to do that, okay? So we'll get into more serious, the Piper 4s and all of that, at another time when they're off, how you handle those. You handle them just a little bit differently, but the thinking is the same. We're going to put the ball back in the sockets. Even though the sockets grew off center a little bit like that, and the ball grew into the socket. So I'll tell a patient sometimes like this, I'll say, well, when you chew on this side, the ball's in the socket and these teeth match. And then when you chew on this side, the ball is in the socket and this side matches. But when you go to chew back and forth, you have to push off sides. So I'll say these joints should be sisters. You have twisted sisters. And the patient kind of laughs, and a lot of people says, yeah, I do have a sister like that, okay? But they get the concept. They get that the two condyles are working against each other in function. And then sometimes that turns into parafunction because the joints would like to center, but the teeth are in the way, so the patient will tend to clench or grind on it or that sort of thing. But the point I started off with is when they come back for maintenance, then they're always adapting over time. So these joints, as they're remodeling, some of them, they'll go sometimes 6 months on their orthotic, and then I'll come in and then I'll close them down, and I'll go, whoa, that's a big shift. But that didn't happen until 6 months down the road. So then I'll have to make a correction in the orthotic. But now I have the condylar position good and healthy. But what does that mean to now the teeth position? Because they're not, if they're still changing and this is still healing and this is still like centering all the way up, they might not have any pain. The headaches might be gone. Okay. Even the clicking might be gone, but it's still in this adaptive
It's still a
mode.
displacement, potentially.
Exactly. So a pseudo disc, I tell the patient, it's much like the heel of your foot. It's like a callus and like that, and then it wears. Or think sometimes on your soles of your shoes, you step and the sole of the shoe wears a little bit off center, and then the podiatrist says, oh, okay, well, you need an orthotic in your foot. But same kind of idea. It's just over a period of time. You can look at the shoes and see how the push off is and how the rubber, back in the day, it was easy to see. The shoes now are so big and thick and rubbery, and people don't wear heels or soles on their shoes anymore. But back in the day, that was easy to see. Even my flip-flops, you can see they kind of wear a little bit differently. But same kind of idea. Patients understand that. Okay, so I'm not talking like centric relationship. I'm not saying those words to the patient. the words I'll use to the patients is, I'm going to put your condyles back in the socket. We're going to put the ball back in the socket, and we're going to get the left side and the right side to work together. But over time, I'm also going to have to make some minor adjustments to your occlusion. So we originally learned equilibration as, okay, I want to restore this case, so we're going to put the ball in the socket, we're going to close you down, and we're going to equilibrate everything in one day. And then that's going to make it easier for me to get to my dentistry. So you were equilibrating for a restorative outcome in the beginning. You were not equilibrating to center the
For
condyle.
prevention.
Yes, as a prevention mode.
To get the bites to match so that when they're chewing, everything's in harmony and they're not crashing into the cusps, and things are loaded in a nice uniform way, so not like you're seeing spikes on one side and not on the other. Is that a good way to explain it?
That's exactly right.
Okay.
Okay, now the advantage of having a T-scan and a sensor is now I can follow the patient over the fourth dimension of time. Okay, so in articulating paper, wipe it off, your record's gone. Okay, but with a sensor, close, tap, tap, now it's recorded. And now I can see the graft, how they go. And I know as they get into the bite, I also mostly know where the push-off is. So over time, it's the disclusion that is now the issue because of the asymmetry. Okay, so 2 bites, condylar position is better, but now the teeth bite, and it's often in crowns. Okay, and it's really common in zirconium crowns. Okay, just because they're unforgiving with it. And what we tend to do with zirconium crowns is flatten them, because it's like, okay, well, I can't do too much, and so you lose the intercuspation that was easier to do in gold. Okay, so the zirconium crowns, many of them just end up just flat, because basically you don't want any of the crashing. Okay, all right, so I see a lot of every single patient. So I see 10 new TM patients a week. That's what happens, but I've been practicing for a long time. That's what I do. So my practice is a joint-based practice, and Jaz got a good dose of that.
It was so well curated, the days from thanks to your team, because I got to see in action. I got to see to do the adjustments, and you're really playing the long game. Like, what I saw, that you're doing little doses of micro equilibrations to get them every 6 months, every year. You're getting the bites closer, but over time. And slowly, as the joint remodels, so it's not like one overtaking the other, it's all happening, and then for a period of time they stay the same on the orthotic, and then you do a little bit more for their daytime bite, so eventually that it's all in harmony. And you're doing it in a preventive way. Now, there's a book, I'm trying to think of the name of the book now, but it's by Nassim Taleb. Do you know this author?
Not off the top of my head.
So here's this book, The Black Swan.
Okay.
But he did some other books. What I like about these books is that it basically talks about, if you were to live your life again in a different parallel universe, okay, the chance of you living this life in this way may not have happened, because you may not have broken your jaw or something. Little things that change your entire course of your life, right? So the way I've started to see dentistry in the last few years is that we're kind of like, actuarists. They look at and they predict the risk of something. Like they predict the insurance and the risk of something, right? And what you're doing in your treatment philosophy that I witnessed over the last few days is that you're like Nassim Taleb in the way that you're trying to give everyone the best shot by putting their best foot forward.
Please, yes.
That's what I'm seeing, because whilst I come from a background of, if it's working for them, if their wear is physiological, then perhaps we don't need to make the 2 bites the one, plus especially if I'm giving them protection at nighttime. But what I'm seeing more and more, especially because the reason I'm here in America and New Mexico with you, is I wanted to benefit from your 40 years of dentistry. And what I've learned is that there is a place for playing the long game, preventive care in terms of occlusion.
The fourth dimension of time.
Exactly.
That's how you play.
And what you're doing basically is that you're allowing everyone to, in a biomechanical, your biomechanical risk is now, obviously we can't control the caries through occlusion, we can't do perio mostly, so bacteria, but in terms of the biomechanical risk and things aging gracefully, that's what I see you doing by trying to make the 2 bites into 1 bite, and you're doing it slowly over time. That's my sort of viewpoint of it.
That's what I want you to take home. That's a take-home message. Okay, now let me explain it just a little bit differently because, okay, so you're playing a game. Okay, so it's a game over time. So sometimes, so the patients, when they know that they're playing this game, they love to stay with it. They don't miss their prophy appointments because they bring in their whatnot. They want everything checked. Okay, how am I doing? And that sort of thing. Okay, but let's say that the patient comes in and they're a new patient, and then I recommend an orthotic. Okay, and so sometimes the patient, they don't get it yet because they don't feel it, but that sort of thing. But they go, okay. But what I told Jaz, I go, look at what you want to do in the beginning is play defense first. Okay, so if you know that you've got 2 bites, okay, and you don't have an acute situation, for example, like a crack that needs attention right away that you need to put a casting on and that sort of thing. So you always have to take care of the acute problem. It might be infection, it might need to be endo, it might be a crack. So go ahead, build it right into what you always know to do. Don't stop your acute care or care that you need to do to get the patient comfortable, okay? So still, you're welcome. Go ahead. Build them in MIP in the beginning. Okay, just know that down the road, you're going to then now have to play defense as opposed to offense. Okay, so what often happens with a dentist is new patient, and the first thing they're doing is lay the patient down, go and now they're looking for cracks. They're looking for some reason to do a casting, some reason to do restorative dentistry. Now, if it's minor, then I want you to know, okay, the crack is there for a reason. It didn't happen. Why is it on that tooth? Okay. What is the location of it? Is it just simply like a hairline little crack, or is it actually the entire tooth is cracked? Those are 2 different things. Okay. All right. But what the tendency is for a young dentist is to, what is the next appointment? So we're going to do a new patient exam. Maybe we're going to give the new patient exam away for free so that I can upsell something down the road so that the next time they come in, I'm prepping a tooth. Okay, that's offense. When you're in only offense mode, and that's all you know as a dentist is to play offense, you're going to lose the game. So remember, in the long run, defense wins championships. So patients get that. So I'll say, okay, I will take care of, in a new patient, I will take care of your acute problem. Since I don't really do restorative dentistry anymore, but I have a team that does. So I'll say, okay, well, I'm going to have this doctor take care of this problem. And so they'll clean up, and it might even be a crown or sometimes 2. Okay. But I know it's in an area that has had high stress into it. And so you're going to improve the 2 bites by building it out of the way, even though you didn't really know exactly where that anterior control was. Okay. But if the way kind of working with sometimes with the patient, they'll be spiking on a back tooth, and I'll go, look, it's like this. You're just going to close down. And then this is what's happening, and that's why you're getting the gum recession, that's why you're getting a little crack, that's why you have the sensitivity, that sort of thing. And so it could be anywhere from a little adjustment to a restoration to center the system. Okay, but I learned early in my career, you're way ahead if you start right away with centering the system, because the patients do well. And sometimes they don't even know that they had a problem.
No, I think, especially when you are playing defense, when you are doing prevention, then it's again, going back to co-discovery and co-diagnosis, about telling the patient in terms of prevention, and they get that. And I saw you do that about in the long term how we're going to make you feel more comfortable, and like it's not like a equilibration one visit like we talked about earlier. What you're doing is it over time. It's like a sequence. So those are my two takeaways. Now this podcast has pivoted into the lessons from Bobby Supple, occlusal views, that kind of stuff, which has been great. But we're going to pivot into abfractions. So what I'm going to do is I'm going to say, because the abfraction version right behind us actually is everything to do with abfraction. We're going to get to the truth of abfraction, because Bobby's done so much studying on this and spoken to so many people and got some T-scan data, which was what we started to talk about it. So I'm going to put this one, because it's so visual, I'm going to put this on Protrusive Guidance for free. It's for everyone. I want the masses to see it. So I'm going to put this as a part 2 now, but it'll be on the community because it's so visual, it's video. So please do check it out.
Well, there we have it, guys. Thank you so much for listening all the way to the end. Hope that gave you a nice perspective, perhaps a different narrative or different way to think about centric relation and how we generally all have 2 bites. I want to thank Dr. Bobby Supple once again for hosting me in Albuquerque, New Mexico, and what a trip it was. Perhaps the real protrusive pearl of this episode should be to shadow more clinicians that you admire and you respect. It was a communication masterclass for me personally. His aura, his authority, but his also kind-heartedness and the way that his team respected him was wonderful. I really loved it, and better than any communication course you can ever go on is just shadowing some clinicians that you really respect. This episode was eligible for CE or CPD. We are a PACE-approved education provider. Make sure you're signed into the Protrusive Guidance app and you got the right level of membership to get your CPD. If you liked AI Jazz, we are in the beta phase of AskJaz. So you can literally have that in your pocket and you can actually call it and have a conversation with me anytime. You can ask any question you want. It's way better than ChatGPT because it's fed on actual data on all the guests we've had, all our trainings, everything that we teach as a paid program has been plugged into this. Trust me, you don't want to delay. Check it out on Protrusive Guidance. There may or may not be a special offer on at this moment because we're just launching it and we're super excited. I want to thank Team Protrusive for helping me set up AskJaz and my AI digital mind, and it's been a really fun process, and we're actually just blown away by how brilliant this product is. I'm so excited to share it with you all. If you want to learn more about that, just head over to protrusive.co.uk/AskJaz. That's protrusive.co.uk/AskJaz. Thank you again, everyone. I'll catch you same time, same place next week. Bye for now.